The most important point in the whole talk on potassium is the one made here by Jan in her write-up. 98% of all your potassium is in the cells. So then what we do is we talk about serum potassium for 40 articles when you realize that's not where the money is. It's mostly in the cell stuff. So how well does serum reflect total body? Just like everything else, it doesn't reflect it very well. So that's point number one. The other thing is that there is no evidence basis for most of these numbers that we come up with. Who in here thinks they know what's a clinically significant low serum potassium? What's the number? What's a high number? It's whatever you want it to be. You have your lab, a clinically significant low number is when the lab slip comes back with a star on it or an asterisk or a panic value that you get called about. We get called about a panic value of like 3.1. I think, no big deal. So that's one of the things that you have to look at here. So there's a couple of real quick issues that have to do with how you get it. If you draw labs through a peripheral IV catheter, will the potassium be the same as if you just did a needle stick and got it? Pretty much. I mean, it depends on how much fluid you let run through it before then, how much you flushed it out with, how long you left the tourniquet on to back up some bloods. But in general, it's fine. It's good, good enough for government work, as we say. Is there any routine value in measuring potassium or anything else in trauma patients? This has been looked at many times. Does it matter? Not a bit. If you have a minor trauma patient, you're not going to do anything where potassium could potentially be an issue. I mean a healthy trauma patient, not somebody who's on dialysis or something like that. But the usual healthy trauma patient, if it's not a real bad significant injury, so what? Almost all of them have a low potassium, and that's a shift. The stress, the high glucose, the epinephrine, whatever it is, drives the potassium into the cells, and when the stress is over, it comes back out and they normalize. That's what it's shown in all of these. I think one of them, 43% of the time, they had a low potassium with trauma. If you have major trauma, now you've got major trauma, you put in the IV, you draw off the potassium, and then you give them 4 units of blood and 6 liters of IV fluids, the potassium you send off to the lab has nothing to do with the potassium that's now in the patient, with the hemolysis from the blood and all the fluids you gave and all the adrenaline stimulated. So for those, it doesn't mean anything either. So basically, what all of these studies show is these so-called screening labs don't really mean anything most of the time. I don't think it's such a big deal. If somebody's major trauma and they're going to come in the hospital for a week and get umpteen bazillion studies, so what? What's the cost of a few more electrolytes? Just don't believe them. I mean, that's the only thing, is that you can't make too much of it. Yeah, number 5, hypokalemia following trauma, 45% happened. I like number 6, hypokalemia in acutely injured children, a benign laboratory abnormality. What was interesting here is number 5, they defined low potassium as 3.6. 6 defined it as 3.0, another defined it as 3.2, another defined it at 2.9. I don't know where they get these numbers because they don't mean anything for the most part. The only thing in here that's sort of a gee whiz, be sure you've heard about this entity, comes up next, hypokalemic periodic paralysis. How many here have themselves diagnosed a case? Hypokalemic periodic paralysis. 1, 2, 3. I've seen one that I think was that. And how many have had more than 3? You might, I was going to say you must work in a genetically, challenged area where these folks come about. It's one of these gee whiz, now you know about it. You'll see it's typically male, sometimes young, supposedly in the middle of the night, sometimes can happen with exertion, and all of a sudden their muscles don't work and they can't walk. And you really think they're nuts. They're hysterical, sure. They couldn't walk then and they're walking now, sure. They're nuts. No, there is that entity. There's both hypokalemic and hyperkalemic periodic paralysis, some associated with thyroid disease, some their potassiums are really low, and sometimes it's just a shift. But it's one of those things, the only clinically significant abnormality for a low potassium that I know of, beside if it gives you a cardiac arrhythmia, is muscle weakness. And in a certain group of patients, it's profound to the point of paralysis. They have a potassium channelopathy. The potassium channels don't work well. And under certain stress, it doesn't work well. Now you've heard it. If you ever see somebody with that, kind of think about it and draw off of potassium. And then when you talk to your neurology consultant, say, you know, their potassium was normal, so I'm thinking it's normokalemic periodic paralysis. Then you've got them, because there is no way to refute that. You know, of course it's normal, but and then there's a whole bunch of articles on should you give them potassium or shouldn't you, and if their defect is a shift of potassium, you'll overcorrect them a little bit. So what? Just know to look these up later on. Can bowel cleansing regimens cause hypokalemia? So you give somebody a bowel cleansing regimen before colonoscopy. Do you think their potassium could be low? Sure. Does it correct itself? Sure. No reason to worry about it. Actually, the one in here, number 12, that looked at it, oral sodium phosphate. I think that's off the market in the States now, if I'm right, because they get phosphate-induced renal failure. So I think the Fleet's phosphosoda is out. You can't do that anymore, as far as I remember. The question would be, how about Miralax? Does that do it as well? That's, you know, Miralax and those Go Lightly kinds of things. Do they make you low potassium? I would assume they would, and then it'll just correct itself as well. Diuretics and the risk of an arrhythmic death in patients with left ventricular dysfunction. There's a whole lot of stuff saying, well, you know, maybe these patients that are in bad congestive failure, they're on a bunch of diuretics and we wash out a bunch of their potassium. Could that lead to more deaths? And even though we don't know it's VFib in most of these people, they have a sudden death, maybe that's what's going on with these folks. And that's a hypothesis here that some people say, well, they die a lot, maybe that's it. We don't know because they don't have it. The only thing I want to bring up a point here is number 13 has to do with methodology. They said they took patients who had potassium sparing and non-potassium sparing diuretics. And they found that the difference in their potassium was statistically significant. The one, the average value was 4.32, and the other it was 4.4. It was statistically significant. Because if you measure enough people, even that 0.08 difference is statistically significant. We know it means nothing clinically. It has no clinical significance. And it has a p-value of 0.0001. I mean, that, for most studies, people go like, wow. Look at that number, 0.0001. And then as a clinician, you look at it and you say, doesn't mean a thing, because it, you know, it's not clinically meaningful. So most of these with patients dying who are on these things are association studies. 15 was one that it's only 2 patients. I know I haven't mentioned this yet, but for those who haven't been to the course before, Hoffman's law of case reports, how many have heard that? Oh, good, then I'll bring that up. Hoffman's law of case reports is that if you ever see a case report about something, you can be assured you will never see it. Why? Because it's so rare that you can actually get a case report about it published. Nobody has a case report, I saw an alcoholic, he fell down and got a subdural hematoma. Case report, flash, you know, because it's so common. But if you, maybe you could put case report, I had one who didn't have a subdural hematoma. Now, maybe that's a case report. But this was 2 patients, and that they were on an ACE inhibitor and a loop diuretic and a potassium supplement, and they came in with sky-high potassiums. Makes sense, but it's case report. Hypokalemia with acute MI, are they at risk for increased arrhythmias? And the answer, I think, here is maybe, but we don't know. The ones who got the arrhythmias also had bigger MIs, higher glucoses, more stress, probably more catecholamines, and therefore their measured potassium was low. Was it the potassium that was low that was the cause, or was it a marker for more severe stress? That's why we don't know. You know, we've tried for years with the GIK studies, you know, glucose, insulin, potassium. We used to think forcing potassium into the cells, that's going to do a good job. And Rick had 1 million of these in the abstracts for years. And every time they studied, there was some guy in South America that thought that this was the thing to do. And they studied it, and they studied it, and they studied it, and they could never prove that it actually did anything for people. To pump glucose and potassium back into the cells didn't seem to matter. So that's about it for potassium part 1. If there are questions, why don't I just let you go and we'll do Potassium, the sequel, tomorrow.